when the Institute was started, my hope was that we would engage in the construction and development of new community sites in underserved communities, that we would train family physicians and other health personnel to be able to staff those sites, and also that we would be engaged in health services research so we could help to move the state of the art and the state of the science of primary care forward.
So the challenges are that many patients don't understand what diabetes is, and they don't understand how it affects their body and how it actually is a disease that can be controlled if proper care is taken in regards to their diet, exercise, and utilization of our support services.
So one of our main areas of research and trying to improve quality has been around looking at the healthcare disparities. So when you think about healthcare disparities, oftentimes people think, well, this is something that you can just kind of fix on a population basis just by kind of doing a better job for people when they come to your health centers. But it's been proven widely across the country that that doesn't really reduce healthcare disparities. In general, the story of healthcare disparities in the United States is everybody's healthcare is getting better, but the gap between people of color and whites has not really been diminishing.
So a lot of our patients actually have diabetes or have increased risk of diabetes, and it tends to be challenging to help patients really understand and grasp the idea of diabetes and the pathophysiology and the treatments for diabetes, to understand how it affects their body, how it affects their lives, and how they can actually take control of it.
I have been working at this site for 2.5 years. We have a large population of patients with diabetes, about 1,400 patients right now that we're serving with diabetes. They come from all corners of the world. We have a lot of immigrants, but we have a large African American population and Hispanic population as well.
I think the main problem and one of the biggest hurdles that we face is that nobody in the traditional healthcare community really believes in health equality. And you see that when you struggle with institutions, that people believe that it's okay to provide something for people who have had nothing, but they don't believe that you have to supply everything and on an equal status for people who are coming in, either previously uninsured or folks who are covered.
When patients come to see the doctor, the doctor only has a limited amount of time to be with that patient, 15, 20 minutes. And they have so much that they have to cover in that period of time. If the patient's coming in because they're not feeling well, the main thing they're going to focus on is what is troubling the patient at the time. And on top of all that, they need to check and see if the patient got their flu shot, everything else, So they don't really have the time to address diabetes prevention.
Accountable care organizations are the next step after you become a patient-centered medical home. But for us in our organization, we believe that sort of being in the lead, being on the cutting edge of healthcare is where we belong. We enjoy innovating. We enjoy experimenting with models of care that are going to improve things. So we're never afraid of sort of leaping ahead with whatever the latest and greatest is to see whether or not it really works on improving care. So, the patient-centered medical home was a transformation process, but we had already done most of that before that designation came out. This is a real leap forward for us. It is a major transformation in the way that we are going to be delivering care over the next few years. And I really look forward to, working with leadership in our organization to sort of forge ahead in this area.
Oh, they're the best. After I start coming on the regular, so they give me good pointers, tell me how to change my eating habits, stay on top of stay on top of me. And basically, they just help guide me to do what I got to do, That's basically eating the right things and take my insulin on time, never missing shots in when I need to take it and stuff like that. So all that's good advice for me, and that's what helps me get through another day.
So the message is very simple about managing diabetes. What to eat, straightforward. How much to eat, very straightforward. What type of medications, what do they do? Why do you need an eye exam once a year? Why do you need to check your feet daily? Simple, but at the same time, it goes through every step of self-management of diabetes.
So we have models now in diabetes specifically, where we've been able to take a group of patients, actually all of our diabetic patients, and we know that when they enter our care, that the African American and Latino patients have much higher levels of A1C than the white patients who enter our care. And we've been able to bring those lines together completely through this model of identifying people who come in the sickest, doing more for them, developing exquisite care systems that recognize that you need to help people catch up, and then bring them all to sort of the same level of achievement in terms of outcomes.
The classes are so enjoyable. So now basically it's like I come every Tuesday, haven't missed a section. So I'm very reliable, keeping track of what's going on, with my diabetes.
And what I think we've done inside the organization that's really made a difference is we've begun to identify the different populations of people. So people who have had difficulty accessing care in the past come in sicker and with both physical problems and problems that have resulted from a lack of access to care over long periods of time. Those people need extra effort. It's almost, we're calling it affirmative healthcare action. They need extra stuff done for them. We can't just do the same thing for everybody and expect to reduce the gap.